So I am thrilled to introduce Dr. Theresa Shao. So Dr. Shao graduated from Yale University and earned her medical degree at the University of Pennsylvania School of Medicine. Dr. Shao completed her internship and residency at Mount Sinai Medical Center, New York. She continued to complete her fellowship in hematology oncology at Columbia University Medical Center. Dr. Shao is currently a medical oncologist at Mount Sinai Chelsea and specializes in breast cancer and GYN cancers. Her research interest focuses on treatment-related toxicity and survivorship. She's also interested in racial and ethnic disparities in cancer diagnosis and treatment. Dr. Shao has received numerous honors over the years, including the Young Investigators Award by the American Society of Clinical Oncology for an innovative study to examine the skeletal effects of long-term biosynthetics in women with metastatic breast cancer. We are so lucky and thrilled to have you join us here today, Dr. Shao. She will be teaching us about immunotherapy. Thank you.
No, thank you, Jillian, for the kind introduction. It's my pleasure to be able to join you guys and to share regarding my talk, which is immunotherapy in GYN cancer. I hope, with this talk, there's so much talk about immunotherapy for all types of cancer. And I hope this talk will familiarize you with immunotherapy for treatment for GYN cancers. And I hope it will also answer so many of the questions you may have about immunotherapy. So immunotherapy, I really think the big part of immunotherapy is T cells. So as we know, there are two types of T cells. One is called cytotoxic T cells. So when they're activated, they can sort of divide and directly kill what we call infected or cancer cells. But their activation actually requires two signals. One is from what they call an antigen presenting cell, and another is from a co-stimulatory molecule. The other type of T cell is what they call helper T cells, and they help facilitate a coordinated immune response, and they can differentiate down a number of pathways based on the cytokine environment. So obviously our body is very good. We have our immune system sort of to keep cancer at bay or in check. So what happens is if you have, if there are cells that change, that develop into sort of cancer, the cancer cells supposedly release some cancer antigen, and they will be picked up by what they call dendritic cells. And these are antigen presenting cells. And they will present these antigen, outside of their cells. And these will be recognized by our T cell, which is our immune system, as foreign. And what happens once it's recognized, the T cells will sort of tell, to divide the helper T cell, the cytotoxic cells, sort of to divide and to replicate. And these T cells will go from lymph node through the blood vessel and then to the tumor to directly kill off the cancer cells. And that's what our immune system is supposed to do to keep cancer under control. So what happened is, so our immune system is constantly looking for abnormal cells and destroys them. So how do we develop cancer? How does cancer evade this surveillance if we have such a, good immune system? Next. So one way, the cancer cells can do this is sort of by expressing or sort of replicating, overexpress this thing called PD-L1. So PD-L1, as shown on this picture, is a ligand that tumor cells can produce. And when you have overexpression or a high number of PD-L1 on the cell surface of the tumor, it can bind to the PD-1 receptor on T cells. And then the binding of this will actually suppress the T cell immune response. And that is one way that the cancer cells can avoid being, killed off by our immune system. So another picture to show this is if you have the tumor cell that overexpress the PD-L1, and then the PD-L1 binds to the PD-1 receptor on the T cells, that's how tumor cells can potentially avoid killing by our immune system. If we can block the PD-L1 or the PD-1 receptor, this will allow the C cells to recognize the tumor cells, and it will increase the immune system to kill off the cancer cells. And this is sort of the, the most common, the sort of immunotherapy treatment that we have for most of the solid tumors.
Good morning. How are you?
And
Okay.
this is what we call immune checkpoint inhibitors. And there's two types, and they're very similar. So one is, if you remember, is what they call the anti-PD-1 inhibitor. These are blocking the PD-1 receptor on the T cells. And there are a few of them, namely nivolumab, pembrolizumab, and dostarlimab. And then the other will be the PD-L1. So these are the blocking the ligand on the tumor cells, and they are called the PD-L1 inhibitor. And a few of them, one of them is atezolizumab. The other is called durvalumab. And I think a lot of you may be familiar with one of them. And these are the common immune checkpoint inhibitors or immunotherapy that we have utilized for GYN cancers as well as other solid tumors.
Before we go further, I just wanted to check in if anybody had any questions. I know that this might be this is above for me in terms of my understanding a little bit. And so I just want to check in if anybody has any questions right now, since that was sort of the early introduction. No? Okay. Thank you. Okay.
So I think the first the cancer I want to focus on is endometrial cancer. So what immunotherapy we have for endometrial cancer. So the first thing that they look at for endometrial cancer is the PD-1 inhibitor, the pembrolizumab, if you remember. And it was first studied in this study called the Keynote 158 study. This was actually a basket study where they have multiple cancers, colon cancer, endometrial cancer. So there was a cohort of endometrial cancer, as well as a cohort of tumor that expresses what they call MSI high, which is microsatellite instability high. So these are endometrial cancer, usually low grade, that is deficient in DNA repair, mismatch repair. So these patients, they usually progress on standard treatments, and they have really no other standard treatment options left. And they were given pembrolizumab IV treatment every 3 weeks until disease progression or toxicity. And the primary endpoint, we're looking at response rate as well as overall survival. And what they find was, next slide. So what they find was in patients in the whole cohort of endometrial cancer, as you can see here on the right side, the response rate is quite low. It was only 11%. However, in the cohort where they express high microsatellite unstable tumor, which is also called mismatch repair deficient tumor, the response rate is very high. It's 57%. So it seems this type of tumor is very sensitive to immunotherapy. And then the graph is just a waterfall plot to see that, there is a significant response in terms of tumor reduction in patients who have MSI high endometrial cancer. And because of this, pembrolizumab was approved in use for patients with recurrent or metastatic endometrial cancer who has progressed on chemotherapy, who have MS-high tumor. Pembrolizumab as a single agent is a very good treatment given this high response rate. And then, as many of you, if you're on immunotherapy, aware, immunotherapy in general is pretty safe and well tolerated. It doesn't have hair loss, nausea that we usually see associated with chemotherapy. However, it does have its own unique side effects. And then the most common side effect is sort of rash, and patient can sometimes also get diarrhea or change in their thyroid function. But in general, most of these side effects are very mild and is very easily manageable. And patients, if they do tolerate pembrolizumab, can continue pembrolizumab or Keytruda for many month or year. So it's a very safe and good treatment option for patients who respond. So because of this study, pembrolizumab alone is approved in patients with MS-high uterine cancer stage 4. So that was the first, drug. And then the second drug that was approved was called dostarlimab. which is similar to pembrolizumab, which is also a PD-1 inhibitor. And this was studied in the Garnet study, which is very similar to the KEYNOTE-158 study, which I mentioned before. They included patients with endometrial cancer, and then those also with what they call, mismatch repair deficient tumor, and patients have progressed, multiple, chemotherapy, exhausted or treatment options, and they were randomized to they were given a dostarlimab, every 3 weeks, and there's also the option of giving every 6 weeks. And what they find was similar to what we saw with pembrolizumab. Next slide. In the whole group of patients with tumor endometrial cancer, the response rate is only about 11%, 13%. But in patients, who had what they call mismatch repair deficient tumor, then the response rate is about 46%. So very similar to pembrolizumab. And then the side effects are also very similar to the, pembrolizumab. And then as such, dostarlimab is also approved in uterine cancer or endometrial cancer who are deficient in mismatch repair. And so these are similar indication for pembrolizumab. So then, patients, so what we do know is endometrial cancer, most of the cancer that has mismatch repair deficient tumor are usually more low grade or endometrial cancer. But we certainly have patients, with high grade tumor, such as uterine papillary serous, clear cell carcinosarcoma. There is a very, a high, unmet need in this group of patients to see if there are any other options, whether immunotherapy will be helpful. So that this comes the KEYNOTE-146 study, where, as we know, pembrolizumab alone wasn't very helpful in this group. So they're looking at exploring the addition of lenvatinib, which is a multi-kinase inhibitor, a small molecule inhibitor of VEGF and other factors, to see if they combine with pembrolizumab, whether it will be helpful for patients with endometrial cancer, such as those with high-grade tumor. So this was a study, for patients with recurrent metastatic endometrial cancer, who had progressed on prior chemotherapy, platinum-based chemotherapy, and they were given pembrolizumab or lenvatinib. So pembrolizumab is IV every 3 weeks. Lenvatinib is an oral medication once a day, and they were assessed until progression or intolerable side effects. And the primary endpoint was response rate. And what we find was, so even in patients who did not have the mismatch repair, deficient tumor, we see a response rate of 34%, which is much higher than pembrolizumab alone. Obviously, in patients who have deficient mismatch repair, the response rate is even higher in 63.6%. And then, as you can see, the patients who respond to the treatment not only are those with proficient or deficient mismatch repair. As I mentioned, patient with clear cell adenocarcinoma, patient with serous adenocarcinoma, which is the more high risk or high grade tumor, these patients also responded to this combination. And because of this, this data, pembrolizumab and lenvatinib are currently FDA approved as second-line treatment for patients with recurrent or metastatic uterine cancer who has progressed on first-line chemotherapy with carbo and Taxol. And this combination was confirmed, in the phase 3 study. So this was the second-line study to confirm the beneficial effect of pembrolizumab and lenvatinib. So these are patients, who have progressed on platinum-based chemotherapy, who have stage 4 uterine cancer, and they were randomized to either pembro or lenvatinib versus physician's choice of chemo. So you can either get doxorubicin or paclitaxel. And what they find is in the study that the pembrolizumab and the lenvatinib arm, if you go to the next slide. So in the follow-up of 11.4 months, the the immunotherapy arm showed a better improvement in progression-free survival, as well as a decrease in risk of death compared to the physician's choice of chemotherapy. There's also improvement in overall survival, as well as median progression-free survival. So as such, right now, pembrolizumab, lenvatinib is pretty much the standard of care second-line treatment for patients, with uterine or metastatic, uterine cancer who has progressed on first-line chemotherapy. So because of such good, result with pembrolizumab, the question, we are asking right now is, can we use this combination in first-line treatment? So can we use it instead of the traditional chemotherapy we give? So this is being studied in the current phase 3 study. So we eagerly await the result of the study. So it is still so the study is closed. We're still looking to see what the result. Hopefully in the next 1 to 2 years, we may have more data in terms of whether we can utilize this immunotherapy combination as first-line treatment for a patient with uterine cancer. So that's one study. And then there is another study that's ongoing, which is the NRG-01A study, looking at if we add pembrolizumab to the chemotherapy arm, whether it will make it better than chemotherapy alone for patients with recurrent uterine cancer. So this is also an ongoing study, and hopefully in the near future, we may have more information in terms of where, immunotherapy is best, for uterine cancer, whether it's in first line, second line, or if it's combined with chemotherapy. So any questions about the first part in terms of uterine cancer? I know there's a lot that I went through.
I ask a question?
Sure.
Thank you. So if I understand right, for people who are not deficient in mismatch repair, the only option is this mix of pembrolizumab and lenvatinib. That still has some good results, well, 34%.
Right. Yeah, it's still better than, you have to understand this is a group of patients who already got chemotherapy, carbo and taxol, who progressed on that. And then if you remember when they were compared to physician's choice, so if we don't do the immunotherapy arm, it will just be other chemotherapy such as Doxil or, Taxol. And then the response rate is even less, it's usually maybe 20% or less. So the combination of immunotherapy is significant improvement over what we can offer a second-line treatment for these patients. Obviously right now, we're hoping to see if we can move up to the first-line, setting. Maybe it will be better than the chemotherapy, and maybe we'll get a longer progression-free survival or overall, response in patient with uterine cancer. Or maybe it's the combination of immunotherapy with chemo that may be better. So that we don't know yet. Right now, the immunotherapy and the lenvatinib, combination is only approved as second-line treatment, for patients who have progressed on prior platinum-based chemotherapy.
Okay, thank you.
I've been on that. I have this microsatellite stable, and I've been on this lenvatinib and pembrolizumab for a year and a half, and I'm got stable disease. In this current study, I believe there's people that are still on it, that it's still working, and that they might be on it more than a year or two, that they've been on it for maybe several years, and it's still working. I mean,
Yeah, so I mean, that's what we find it quite impressive with immunotherapy. So, what we know is, old days, with chemotherapy, very difficult for patients to tolerate chemotherapy for a long time. And inevitably, patients progress on chemo. But for the immunotherapy, the pembrolizumab and the lenvatinib, there are patients who respond, like you, and then other patients who may have continued response, beyond 1 year, sometimes 2 or 3 years. So there are patients with long-term responder and who actually can tolerate the medication well, can continue on. So absolutely, and that's what we like about the immunotherapy, treatment, because it's usually well tolerated, and we don't see what they call long-term, side effects. If patients don't have side effect initially, usually the immunotherapy can be continued, indefinitely, for long, as long as patients continue to respond.
Thank you.
Anybody, any other questions for right now in terms of what Dr. Shao spoke about? Mimi, I do see your question in the chat. Dr. Shao hasn't started talking about ovarian cancer, so I'd like to see if she gets that question. Otherwise, of course, when we get to that point.
Okay, so if no more questions, so then we can move on to cervical cancer. So immunotherapy has also changed our treatment landscape for cervical cancer. As a lot of you know, cervical cancer, especially stage 4 cervical cancer, is quite difficult to treat. For patients who's progressed first-line platinum-based chemotherapy, usually second-line treatment options are very limited. Response rate is usually 10% or less, and the duration response many times is less than 3 months. So this is a very poor patient population. So pembrolizumab, what we mentioned before for uterine cancer, has also been studying cervical cancer. So the first study that looked at this was this study called the KEYNOTE-158 study. So this was a study looking at patients with recurrent or stage 4 cervical cancer who have progressed on prior first-line platinum-based chemotherapy and who had a PD-L1 expression. This is an expression greater than or equal to 1%. So this is on the tumor cells. And what they find is, patients who treated with single agent pembrolizumab had a response rate of 15%. It's not impressive, but compared to a lot of the second line treatments, it's usually less than 10%. But what is impressive is if patients who did respond to the treatment, the duration response is quite high. So in the study, at the median follow-up of 10.2 months, the median duration response has not been reached in this patient. And, and we do know that patients who responded to the treatment can respond for a year or 2 or longer. So this we have never seen for any other treatment. So it has been very impressive for patients, who respond to pembrolizumab in this setting. The response rate seemed to be durable and also long lasting. And then there was another study called the KEYNOTE 028 study where they showed a similar response. And then, so as you remember, just as with uterine cancer, this was approved in the second line setting. Obviously, we were interested in to see if we give it in the first line setting, whether we will have a better response and a better duration response. And this was studied in the KEYNOTE 826 study, which is this phase 3 study looking at patients with recurrent or metastatic cervical cancer, newly diagnosed, and they were randomized to either chemotherapy, which is cis or carbo plus paclitaxel, plus or minus bevacizumab, and they get randomized to either receive pembrolizumab or not. And they look at overall survival, progression-free survival, as well as overall response rate. And then this study was just recently published in the last couple of months. And next slide. And as you can see, in patients who received pembrolizumab, there was improvement in progression-free survival, from 10.4 months to 8.2 months. And the hazard ratio was 0.65. So this is pretty impressive. There's also improvement in overall survival. And because of this data, now pembrolizumab or Keytruda is approved approved as first-line therapy for patients with newly diagnosed uterine cervical cancer in combination with platinum-based chemotherapy plus or minus Bev. And so this was, I was just going to mention, so as I mentioned earlier about the side effect from these immunotherapy. So usually, most of the side effects are immune rate mediated, and most commonly are diarrhea and a rash. If it's mild, patients usually don't have to do anything. If it gets to more moderate, then most likely we have to hold the drug. And sometimes we have to initiate steroid, because what happens is these are side effects that when your immune system is so augmented, it may start to attack your own cells. So steroid is a very helpful thing to do. And then we try to taper the steroids. If the side effects subside, then patients may be treated with immunotherapy again. But if the side effects do not subside or do not improve, then sometimes we have to consider immune suppressive agents and permanently stop the treatment. I mean, these are still very rare side effects. Most of the patients who are on immunotherapy do not really have these side effects, or if they do, it will be very mild. But this is something just to keep in mind. So, in summary, for cervical cancer, pembrolizumab is approved as a single agent, in the second-line setting for patients with PD-L1 positive cervical cancer. And now it's also approved in the first-line setting in combination with platinum-based chemotherapy plus or minus Bev for patients with recurrent cervical cancer. Any questions about cervical cancer?
I guess I'm curious, how would you decide, like, knowing that it has been approved for a first line, how does an oncologist make the decision of what they're going to give?
Yeah, so
if you're seeing a woman with cervical cancer, when would you say, you know what, let's try the immunotherapy for this because it is appropriate or not?
Yeah, so usually what happens for most of the treatments is usually study at later stage, right? So later lines, and once it has its efficacy, then it move up to the front line. So if I meet someone with newly diagnosed cervical cancer, now obviously I would like to incorporate, pembrolizumab into their chemotherapy regimen because of the improvement in progression-free survival, overall survival. So now this is pretty much a standard of care, for patients with newly diagnosed. But in the past, we didn't have that option because it wasn't approved. So, Keytruda or pembrolizumab was only utilized in the second line setting because that's what the approval is. But now we know that it works in the first line setting. Obviously, I want to give my patient the best choice because some patients may not be able to make it to the second line setting. So if this is something that will make patients' disease better and improve their survival, obviously this is something that we want to incorporate as soon as possible. So in the first line setting. So nowadays for cervical cancer, if patients, newly diagnosed, metastatic or recurrent, we would like to incorporate pembrolizumab with the chemotherapy regimen.
Thank you. Does anybody else have questions in terms of cervical cancer and immunotherapy?
So moving on to ovarian cancer, obviously ovarian cancer is probably the cancer that, we need, a lot of patients have and it needs treatments. Unfortunately, obviously immunotherapy has been studied a lot in ovarian cancer, but unfortunately immunotherapy hasn't been as helpful or, in uterine cancer or cervical cancer as in ovarian cancer. So I just want to mention, but obviously we are still working on, there's still a lot of ongoing trials to look at, this immunotherapy ovarian cancer, and hopefully in the near future, we may have more data and there, to see whether immunotherapy will be helpful in ovarian cancer. So immunotherapy was first, studied. There are a lot of immunotherapy that have been studied. I mentioned one of the drug, the pembrolizumab. It was studied in this study called the Keynote 100 trial, which is a phase 2 single arm study. They look at patients with platinum sensitive or resistant recurrent ovarian cancer. And then they were giving pembrolizumab 200 milligram IV every 3 weeks. And unfortunately, as you can see from this chart, the overall response rate was only 10%. So it was very low. It was not better than, chemotherapy or other treatment options we can offer. They do see seems to be some increased response if you have a higher PD-L1 expression. So it seems like tumor who, expresses PD-L1 may, higher expression may suggest a higher response to pembrolizumab. But overall, the response rate was still on the lower side. So as a single agent, pembrolizumab doesn't seem to do much for ovarian cancer. Now it is being studied to be utilized in combination with chemotherapy. So there was a study called the FIRST study where we also participated. We may have patients who were enrolled in the study. This was a phase 3 study for patients with newly diagnosed advanced ovarian cancer. They were getting standard chemotherapy, carbo and Taxol plus or minus Bev, and they also were randomized to this PD-1 inhibitor called TSR042, and they will continue with the PD-1 inhibitor every 6 weeks for about 35 cycles, and they want to know whether the addition of this immunotherapy to chemotherapy will be helpful in terms of improvement in progression-free survival as well as overall survival in patients with advanced ovarian cancer. The study is currently, close to accrual, but it's ongoing. And we hope in the very near future, if we may have some data in terms of whether combining immunotherapy will be chemo in the first line setting will be helpful. There is also an ongoing trial. We have it open here. It's the NRG 009 trial, where this is for patients. It's a phase 2 and 3 study in patients with platinum-resistant ovarian cancer, looking at the combination of doxorubicin plus or minus Bev, and plus or minus the PD-L1 inhibitor, atezolizumab. This is to see if we add immunotherapy to chemotherapy in patients with platinum-resistant ovarian cancer, whether it will be more helpful than chemotherapy alone. So this study is ongoing, and we certainly have patients who are enrolled in the study, and hopefully in the near future, if we have the data of the result, maybe it will shed more light in terms of what is the role of immunotherapy in patients with ovarian cancer. But right now, immunotherapy is now approved in ovarian cancer in any setting. And as a single agent, the response rate is really on the lower side. So that's all I have for ovarian cancer. I don't know if anyone have any questions. I mean, there are also other studies, looking at immunotherapy for ovarian cancer. I just mentioned a couple of studies we have here, but there are actually a ton of studies because immunotherapy is a very hot topic. And we hope that, there is something that we can find for ovarian cancer patients as well, that we can utilize immunotherapy. Thank you.